Hey everyone, and welcome back to our YouTube channel for another weekly video. My name is Caroline, and I am a nurse practitioner and instructor with SMNP Reviews. Today, we will be working through a few practice questions that are similar to the ones that you may see on your AANP or ANCC board examination. As we go through them, I'll point out helpful tips that will make answering questions on test day a little less stressful. I also want to mention that our course offers an exceptional question bank with over 1,000 questions, which is the minimum recommended amount that we suggest before testing. So you should definitely check out this resource if you haven't already. Also, don't forget to click the subscribe button so that you can continue to stay up to date with our latest weekly YouTube videos. Now, before we go over some practice questions, I do want to address a common challenge that many students encounter: choosing between two answer choices. Oftentimes, students tell me that they can narrow their answer choices down to the last two options, but are unsure about how to proceed from there. Well, first and foremost, it's important to stay calm and focus on what the question is really asking. Take a deep breath and reread the question to see if there are any keywords or phrases that can help guide you to the correct answer choice. Another important piece of advice to remember is that your gut instinct is usually correct. I know it can be easy to talk yourself out of an answer choice. However, we really encourage you to stick with that gut feeling unless you are 100% sure that it is not correct. Studies have actually shown that your first instinct is typically the correct answer. Lastly, when in doubt, look for the answer choice that prioritizes patient safety. The AANP and ANCC board examinations want to make sure that you are a safe, competent, new graduate nurse practitioner, so always look for the answer choice that makes patient safety a priority. Let's go ahead and get started with our first practice question. A 74-year-old patient presents to the office for a routine examination. While assessing the patient's eyes, the nurse practitioner observes a gray halo around the cornea. What is the most likely diagnosis? Is it A, arcus senilis, B, macular degeneration, C, presbyopia, or D, xanthelasma? Go ahead and pause the video if you need to take a few moments to think about the answer and come back when you're ready to review. When considering the most likely diagnosis for this patient, it is important to look for keywords or phrases in the question, as these can help us get to the correct answer. Do you notice any pertinent information in the question that can help guide you to the correct answer choice here? I noticed the patient's age and the phrase gray halo around the cornea. This information is vital for making our answer choice selection. So, what condition are you thinking that our patient has? If you chose option A, arcus senilis, you would absolutely be correct. This can be seen in the eyes when the edges of the cornea develop lipid deposits and cause a benign gray ring to form. Keep in mind that an increase in cholesterol can lead to this condition. However, we consider it to be benign in the older adult population. Now, what if the patient in this scenario would have been 22 years old? What lab would we want to draw then? Definitely a lipid profile. Keep in mind that younger patients with this condition usually have familial hyperlipidemia and may be placed on a statin. Now, some of you may have been torn between another option that has to do with elevated cholesterol, option D, xanthelasma. But remember, xanthelasma is seen on the eyelids, not on the eye itself. Xanthelasma is also often benign in the older adult population, but once again, in younger patients, it could suggest an underlying issue with elevated cholesterol. Let's look at option B, macular degeneration. Do you remember what this is? That's right, it is the loss of central vision. Bonus question here. How might straight lines appear to a patient with macular degeneration? You've got it, wavy. Now, this condition does not cause a gray halo to form around the cornea, so this answer choice could easily be ruled out. Lastly, let's look at option C, presbyopia. Do you remember what this is? This eye condition makes it difficult to focus on nearby objects and therefore is often referred to as short arm syndrome. Subsequently, presbyopia does not present with a gray halo around the cornea, so this was another option that was a distractor and could be ruled out. It is very important to be able to differentiate eye conditions not only for your exam, but also for practice. Our courses break these topics down and make them easier to remember, so be sure to check out the videos on various eye conditions if you haven't already. Moving on to our next question. A 15-year-old boy presents to the nurse practitioner reporting severe testicular pain. Upon assessment, he has an absent cremasteric reflex. Which of the following is the most likely diagnosis? Is it A, epididymitis, B, Peyronie disease, C, prostatitis, or D, testicular torsion? Go ahead and pause here again if you need to, and then press play when you're ready to go over the answer together. Okay, let's review this one together. An absent cremasteric reflex is a giveaway for which condition? You've got it, option D, testicular torsion. Remember, the cremasteric reflex is the elevation of the testicle in response to the upper inner thigh being stroked. Normally, the testicle should rise when this area is stroked, and an absence of this sign would cause the nurse practitioner to suspect testicular torsion. With testicular torsion, the testicle is unable to rise due to the twisting of the spermatic cord, leading to an absent cremasteric reflex. Bonus question before we review the incorrect answer choices. What would you do if a patient in primary care presented with an absent cremasteric reflex? Absolutely refer, refer, refer. Without immediate intervention, this condition can lead to a loss of blood supply to the testicle, permanently damaging it. Now, let's look at option A, epididymitis. Do you remember what this is? This is caused by inflammation of the epididymis and is not associated with the cremasteric reflex, but rather the Pren sign. Do you remember how to perform the Pren sign? The examiner will lift the scrotum and the patient will feel a relief from pain when it is elevated if the patient has epididymitis. Now, what about option B, Peyronie disease? Do you remember what this condition is? Well, this condition occurs when a patient has curved, painful erections. I like to remember this condition because the word Peyronie has a Y in it and the letter Y is curved. This answer choice was truly a distractor and could be eliminated as our patient was reporting testicular pain, not penile pain. Lastly, let's look at option C, prostatitis. Once again, this answer choice is a distractor as our question is discussing testicular pain, not prostate pain. Do you remember how prostatitis might be described on a digital rectal exam? That's right, the prostate may be described as warm, tender, swollen, or boggy, all of those words that have to do with infection. It is important to be able to differentiate the various men's health conditions, not only for your board examination, but also for practice. Let's dive into another one together. A 65-year-old patient presents to the nurse practitioner reporting a painful vesicular rash surrounding their right eye. After a thorough physical assessment, the nurse practitioner diagnoses them with herpes zoster. What should the nurse practitioner do next? A. Administer acetaminophen or Tylenol. B. Prescribe acyclovir or Zoravax. C. Prescribe sulfamethoxazole, trimethoprim, or Bactrim. Or D. Refer the patient to ophthalmology. Go ahead, pause if you need to, and then we will review this one together. So let's use the strategies that we discussed earlier and look for some keywords in this question. First, what is another name for herpes zoster? Shingles. Is there anything else in this scenario that sticks out to you? What about the location of the shingles? That's right, it is around the patient's eye. So what do you think the nurse practitioner should do next? Definitely option D, refer the patient to ophthalmology. Remember, when shingles is around the eye, it puts the patient at risk for permanent blindness and corneal scarring, and referring the patient is going to be the safest course of action for this patient. Let's take a look at option A, administer acetaminophen or Tylenol. While this medication could provide some relief from pain, It does not address the urgency of the situation, so it can be ruled out. What about option B, prescribe acyclovir or Zoravax? While this medication is used to treat shingles, referring to ophthalmology will be more appropriate as the patient's vision is at stake. This is an example of choosing the most correct answer choice and keeping safety at the forefront of our critical thinking and clinical decision making. Lastly, option C, prescribe sulfamethoxazole, trimethoprim, or Bactrim. Well, is shingles a virus or a bacteria? Absolutely a virus caused by the varicella zoster virus. So this was another answer choice that was a distractor. Great job working through that one. Let's move on to our last practice question that we are going to walk through together. A 45-year-old patient with type 2 diabetes mellitus consistently reports low blood glucose levels at 3 a.m. and high blood glucose levels at 7 a.m., despite adhering to their diabetes management plan. What is the most likely diagnosis? Is it A, dawn phenomenon, B, insulin resistance, C, Somogyi effect, or D, sundown syndrome? Take some time to pause the video to think about your answer and then hit play when you are ready to walk through this one. So, the patient in this scenario is experiencing hypoglycemia at 3 a.m. and hyperglycemia at 7 a.m. Do you remember what this is called? You've got it, option C, the Somogyi effect. The word Somogyi sounds similar to the word tsunami and helps me to remember that patients with this condition experience that dip in blood glucose in the middle of the night, followed by that rebound rise in the morning. Bonus question, do you remember some ways that we can prevent that middle of the night dip from occurring? Well, we could lower their insulin dosage at nighttime, we could have them eat a bedtime snack, and we can ensure that they are not working out right before bed. Let's review our incorrect answer choices. Looking at option A, the dawn phenomenon, is often confused with the Somogyi effect, but they are indeed very different. The dawn phenomenon occurs when there is a steady rise in blood glucose throughout the night. I like to remember this by thinking that the patient's blood glucose rises like the dawn. So, how do you think this condition is managed? Well, we need to increase their bedtime insulin to try to help regulate the blood glucose throughout the night. What about option B, insulin resistance? While this term is related to diabetes, it does not give the explanation as to why the patient is having fluctuations in their blood glucose at specific times. Lastly, let's look at option D, sundown syndrome. Well, friends, this one is a distractor. Sundown syndrome is unrelated to diabetes mellitus and often has to do with dementia. This was a tough one, but awesome job sticking around and critically thinking through all of these questions. You all did great. Congratulations, everyone. You've made it through another video. You're one step closer to becoming a real deal nurse practitioner, and we are so proud of you. I encourage you to take a look at our question bank if you haven't already, as we have tons of questions similar to the ones that we just reviewed that can really help as you prepare for your AANP and ANCC exams. Keep up the great work, and we will see you back next week for another video.